First of all, thank you all for staying through the conference. We've had an amazing time. I think we've seen some amazing speakers. I've learned so much, even after 25 years, still learning. And I'm sure the younger families and the folks that haven't attended as many conferences as I had the opportunity to, that there's just been a great learning experience over the weekend. And there's also been wonderful camaraderie and networking and the socializing last night. I was so happy to see our adults out in the lobby and then going on to dinner. Was really just what we had hoped for. So thanks for being here. Our presentation this morning is on anxiety and depression across the lifespan, discussing signs for identifying it and strategies to cope with it. Mental health in people with spina bifida is just beginning to be researched and yet has a critical impact on a person's quality of life. Dr. Aurora Rivendale, psychiatrist at the Timothy Freeman Center for Intellectual and Developmental Disabilities at UC Health, and Dr. Nick Hartley, psychologist in the Division of Developmental and Behavioral Pediatrics at Cincinnati Childrens, will share behaviors and symptoms that might indicate a child or adult with spina bifida is struggling with anxiety and/or depression, and some of the root causes related to this diagnosis. They will also discuss strategies to implement at home to help address these symptoms and when it might be appropriate to seek professional help. So welcome, Dr. Hartley and Dr. Rivendale.
Well, welcome. Thank you for having us. We are so excited to be here and so wonderful to hear that the conference has gone well so far. And we are honored to be here to talk about anxiety and depression, a topic that's not always easy to discuss, but very important, especially in the spina bifida community, that's sometimes lacking in the research and knowledge of what this might look like across individuals and across the lifespan. So today we don't have any disclosures on the presentation. And today we're hoping to help you understand what the signs are of anxiety and depression, what symptoms might occur, what it looks like in our diagnostic manuals in terms of symptom criteria. We hope to help you identify factors, even general factors, and then more specific to spina bifida that might be impacting anxiety and depression and increasing that. And then we hope to help you understand better strategies that might help mitigate the impact. And this is a nice small crowd today, and we're here to provide some information, but we fully know that you are individuals and parents who know a great deal about this subject, I'm sure, as you've lived it. And we hope that if there's any questions along the way or anything that you would like to talk about with us, we can make this more interactive today. So please feel free to shout out anything, and we'll include you too along the way. So I am Dr. Nick Hartley. I am a psychologist at Cincinnati Children's Hospital. I primarily work with children with autism and other developmental disabilities, where I'm providing differential assessments to assess and diagnose certain diagnoses. And I'm also involved in some treatment. I work a lot with anxiety. I run an anxiety group there. I work with smaller kids with autism doing ABA therapy. And then I also do some work within the Spina Bifida Center. So they often refer kids and adolescents to us to do some therapy. And I just wanted to talk a little bit about the Children's Hospital Spina Bifida Center. It is available for whoever might need it, but it is unique in that it's multidisciplinary. So they will have families come for one day, and the families will work with a multitude of providers, specialists that day. They provide care coordination, so getting the individual to where they need to go. And that it is, a leader in terms of research and development and diagnostics and clinical care of spina bifida. So if you are interested, or if you're If you are not associated with that center, the number is there and you can call for more information.
Great. Good morning, everyone. I'm so glad to be here. My name is Aurora Rivendale, and I trained here at University of Cincinnati in family medicine and psychiatry, and developed during my residency a really strong connection and interest in working with adults with intellectual and developmental disabilities and focusing on their mental health, because I found there was so much overlap between the medical need and the mental health need. So I'm really, really lucky that I graduated when I did, and I got to meet, for those of you who don't know, Dr. Lauren Wong. She's the medical director of the Freeman Center, which is a rather new organization here in Cincinnati. But we serve a lot of folks who come from far away. So depending on where you live and what you're needing, we are a unique center that offers primary care mainly for adults with any intellectual or developmental disability, including individuals with spina bifida. And the Freeman Center, I'll just say a little bit more about it briefly, is interdisciplinary. So means that not only do we have multiple specialists located, such as physical medicine and rehab, psychiatry, therapy, and we're ultimately going to have speech, OT, and dental down the line. It's probably a couple years down the line, but coming. We all meet together and talk together. We also have nutrition available, dietitians, and we connect with the larger academic center and help communicate with the specialists, even if they're not co-located at our center. And for those who are not needing primary care, because that's kind of the entry point for the Freeman Center, but who do need mental health care, we have a separate clinic right now. That's the mood disorder clinic. I don't have that number on here, but I can give it to anyone who is interested, or I could say it right now if people want to go ahead. So the mood disorder clinic number is 513-585-MOOD, which is 6663. So I work at both of those locations, and my passion is really just helping figure out how to help people live their best life and succeed, because I think that mental health is sort of the core and foundation for all health.
So we want to start with asking, why do we focus on mental health? And it really is an important topic to understand how to live our life to our fullest. It is a constant process for everyone to find balance, to live life to their fullest. And as we know, everyone sometimes faces anxiety and depression that might hold us back from what we want to accomplish in life. And so particularly in spina bifida research, more focus has been on the physical or the neurocognitive aspects of spina bifida, and not enough probably focused on the mental health aspect. So we want to talk about that today, have that discussion with you so that we can start to open it up and talk through it with each other.
So we had this idea of doing a word cloud, but I know that these things are always a little difficult to like get out your phone and do all the things at once. So we thought, since we had such a small group, if you wanted to, we had this question: what words or phrases or even questions come to your mind when you think about mental health and spina bifida? And you can just shout them out if you don't mind. Difficult. Great. And I'll repeat what I hear. Make sure I get it right. Anxiety. For families and individuals, right? Yeah. Waiting for the next shoe to drop. Waiting for the next shoe to drop. Low self-esteem. Low self-esteem. What if? Loneliness. Loneliness. Yeah. Fear. Isolation. That's on that here. It's not meant to. Yeah, so I think, I mean, what I kind of hear is mental health is kind of scary, right? Like when things go wrong, it can be overwhelming and it can take up a lot of our time, space, and energy. But we hope to bring in some more of the antidotes to some of those as we go through.
Maybe resilience too, but resilience that comes from necessity.
Yeah, resilience from necessity. Yeah, which is sometimes unfair, right? And kind of like it just sucks, you know. I don't want to have to do this. Or it's like when people say about getting old, like, oh, getting old is not for the weak or something. It's like, well, I don't really have a choice, right? I'm just getting old. Can't do much about that. I wanted to share the beginning of a story of a patient that I worked with. I'm just going to call her Sally for right now. So Sally came to me at the Freeman Center when I was actually still doing primary care. I do mostly psychiatry and consults now. And Sally is in her late 40s. She was in a relationship. She had spina bifida. She had decent mobility, but did have to do straight catheterizations. She had a job. She was in a relationship. And she came to me primarily with just symptoms of depression, feeling just kind of blah, not wanting to get out of bed, was going to work, but just didn't enjoy it the way she used to, wasn't feeling connected to her partner or engaged very much in her life, and just felt out of sorts. We did sort of your standard, we checked on some medical things, made sure there was nothing out of line there, like her thyroid function was normal, she wasn't anemic, she was eating okay. Nothing else had really changed. There hadn't been a major stressor that we could identify at first. So we said, okay, you meet criteria. You've had these symptoms for more than 2 weeks and they're really disrupting your life. And so we decided to start medicine and engage in therapy, which I'd already sort of done some of, but was getting back into. And so I'm going to pause there and just say we started the medicine, and we'll see what happens down the line and what we learned as I got to know her a bit more. So I'll talk a little bit about what is depression, and Sally kind of had some of these symptoms. I don't know if you can read the fine print up there very well, but I'll just go over the key points. This is the fancy criteria in our manual, but I always tell people the manual is not the end-all be-all of what symptoms are. It's a guideline and it's a common grouping of symptoms. But ideally, when we're thinking about depression, it does need to happen over a certain amount of time. It doesn't mean once a month I'm sad or when I can't get out of bed. It has to be a little bit more frequent than that. And it has to be different than baseline. Some patients may struggle with that for many different reasons, and it may not be related to depression, right? And the symptoms have to cause distress, meaning that the individual really notes that they are just not doing well and that it's bothering them. And we have to rule out, like I said, medical problems, and then mental health issues apart from depression. So anxiety, ADHD, change in brain functioning, like people who have had a stroke, things of that nature can cause it. And of course, you know, we're all human. Substances can impact all of us, you know, so alcohol use, marijuana use, any other, even too much caffeine causing poor sleep and other things of that nature can impact us. So typical things you might be asked about or think about for yourself is, how am I eating the same as I usually do, as long as I'm medically well? Am I sleeping more or less? Not being as engaged, with your social activities, your friends, things that you enjoy doing. We talk a lot about that enjoyment piece. Let's say you love playing video games, right? Like, I don't know, Animal Crossing is your favorite thing ever. And that's what you love to do. And you're just kind of bored with it, or you don't want to do it. Or you always love to go out to coffee with friends and you're just not, you keep saying no and you find an excuse. That could be a sign of depression. So it's something to just pay attention to. Some people also may just note more irritability. I think that's one that we ignore sometimes. We're just like, oh, I'm just irritable. I don't want to be bothered. And that can be a very common sign of depression that gets kind of swept under the rug. On the more extreme end, there can be lots of negative thoughts. Some people mentioned low self-esteem. We can have bad thoughts about ourselves. This is all my fault. I'm responsible for everything going wrong. Or even if someone doesn't call you back, oh, it must be that, they hate me because I'm a terrible friend. I can't possibly be a good friend. Those kinds of thoughts where we blame ourselves completely for things that aren't within our control can also be a sign that depression is creeping in. Anything to add? I'll take a brief moment to talk about some things I can see when people get very depressed, because we know that our individuals who experience, especially our adults who have any kind of developmental or intellectual condition, can be at more risk for some of the more severe complications of depression. How many people have heard the term catatonia before? Okay, a lot of you, great. So this is an extreme complication of depression, but it can happen to a lot of individuals where they may change completely, not just be depressed, but it can be preceded by a period of depression. And people can start to move more slowly, have things where they put their bodies in odd postures for long periods of time, stop eating, stop taking care of themselves, or forgetting how to take care of themselves, and not talking, or talking so softly you can barely hear them. That's definitely something where you're like, you need to get to your doctor as soon as possible. There's no, that needs medical attention, because medical things can also cause that condition. Another thing that sometimes you might hear people talk about is depression with the fancy word we use is psychotic features. I call that depression with a break from reality, meaning that we start to maybe have symptoms of either hearing things or seeing things. Maybe not as common, but it's almost as if those symptoms I talked about before of depression, where I feel really guilty, or I start to think that other people don't like me, they get so extreme that I might start to believe, oh, my mom or dad really don't love me anymore. They're not my mom or dad. I'm not part of this family. You could get these kind of very intense beliefs, and you can't be convinced otherwise. That's a sign of a more severe depression. And of course, depression can come with thoughts of just not wanting to be here, right? I think we all know about that, thoughts of not wanting to be alive. Those don't have to come with catatonia or those break with reality symptoms. Those can come at any time. When I get concerned as a physician talking with my patients is when someone tells me they can't find any reason to keep going, or they're telling me that they're starting to think about how they might take action. I always reassure people, you're not going to go to the hospital if you have thoughts of harming yourself. Those just tell me, gosh, you're suffering right now. You're really feeling depressed. So we need to do something. We need to do something differently. So I always try to reassure people, it's not like you tell me, well, I thought about driving this way on the highway, and I'm not going to put you in the hospital. We're going to talk about it and have a conversation. I think a lot of people don't feel comfortable sharing those thoughts out of fear. So I always try to reassure people it's always a conversation, and hospitalization is a last resort to keep people safe.
And just to touch on that last topic, I do encourage families to talk openly about those thoughts that they might have. Just because we're having those thoughts doesn't mean by talking about it more is going to make us more likely to do something. So it's more important to have an open conversation and a plan where everyone is involved in your care team rather than suffering alone. And if it does get to a point where we need to maybe up our level of care, it is important to talk with maybe a trained professional to help you with maybe coming up with a safety plan or something to do if you're having certain thoughts or along different levels of where you are. So safety plans can be very helpful. Yeah. So I'm going to talk about a little bit about anxiety. And as you can see, as you probably know from your own anxiety and the symptoms that Aurora just talked about, anxiety and depression can look very similar. They often have overlapping symptoms that can be difficult to tease apart. So sometimes anxiety and depression can be two sides of the same coin. I always talk about one is maybe sometimes leading the other. It's kind of driving the train. And so, if we're so anxious that we can't go out and do anything that we enjoyed, or we're constantly worried or fearful, then it's going to make sense that we're losing pleasure in things that maybe we enjoyed. And vice versa, if we're sad or feeling lonely or worthless, and we're not getting things done maybe at school or work, then that's going to increase our anxiety because we're going to maybe feel like we're falling behind. So they are very co-occurring, and it's often more common to have both than one or the other. But anxiety is an emotion that we all have. It can be a very helpful emotion, right? Because anxiety in its core can keep us safe from things. It can keep us aware of maybe upcoming deadlines or not traveling across a busy highway, right? It'll keep us safe at times. It's a normal emotion that can be helpful. And it dates back to our earliest ancestors, where maybe they were needing to hunt and gather for all of their meals. And they were running away from tigers and bears, where they constantly needed that body's response to a real fear and stimuli. But what's happened over time is we don't have those saber-toothed tigers following us around so much. Now we have other problems where it's still eliciting that same response, but it doesn't. With the tiger, once we're free and safe from the tiger, our body naturally goes back to homeostasis. But sometimes with chronic anxiety and chronic worry, it can start to debilitate us and start to make us, not really able to function. So I think anxiety becomes a problem when it's starting to impact our level of function. The DSM talks about 11 anxiety disorders. And the DSM is our manual that we all use to treat and diagnose mental health and developmental disorders. OCD is actually was considered an anxiety disorder at one time, but it's in the most recent manual has been pulled out as its own separate thing, just with the consideration that it's impacting different parts of the brain than maybe other anxiety. OCD is more of a frontal part of our brain, where anxiety is different. But I'll talk about the main ones. Are generalized anxiety disorder. This is where we have persistent worry, rumination, fear about upcoming things more often than not. Social anxiety is another one. This is where we fear judgment. We fear being in groups of people. We constantly worry about the next time we have to talk to someone. Specific phobia is when we have intense fear or anxiety about a specific object or person or situation, so much so that it often keeps us inside, keeps us away from people. It elicits a panic response where we might have a lot of intense reactions. Panic disorder. Separation anxiety can be fear of leaving a caregiver or our home, because we have attachment to that, and to the point where maybe we can't go to work or school. Sometimes with separation anxiety with younger kids, we might see an anxiety disorder called selective mutism, where we're very much not comfortable talking with people outside of our home at all. And then panic disorder is where maybe we have a lot of physiological symptoms of rapid heart rate, sweating, intense deep breathing, high ventilation, yes. And that's more, those are all symptoms of our body's response to the fight or flight reaction. And who's heard of the fight or flight? Yeah. When we are faced with a stimuli, then our body decides, are we safe? And if not, how do we get out of this? So we either fight it, face it head on, or we sometimes try and get away from that situation and avoid it, or we sometimes can freeze and just not know what to do there. So some common signs and symptoms of anxiety include a lot of rumination and worrying about maybe upcoming things. We can't get our mind or thoughts off of a certain trigger or thing that happened to us. We often engage maybe in rituals with more OCD to avoid the triggers or bad outcomes, and sometimes feel like we have to do that behavior in order to protect ourselves. We do try sometimes to avoid triggers. This can be social isolation, keeping us in our safe spots or places, so that we are keeping ourselves away from being triggered. Blending in or being a wallflower. This is sometimes common in individuals with spina bifida, especially, where we don't want to maybe appear different than our peers. And we tend to maybe say things that appease other people for fear that we might have conflict with them, or we would stick out. And so with blending in, sometimes that involves some dishonesty with some of our kids, where we might try and fabricate things maybe we've done with our daily routine, or other things, just to keep us from having to face that. Nightmares or flashbacks can be a common one, especially with trauma and PTSD, which is extreme anxiety about a specific thing that's happened to us. And then agitation, so it's just our physiological body's response to things. We can feel uncomfortable or nervous. Irritation, like in depression, especially for younger kids. So sometimes if you have a younger kid with at all, or with spina bifida, sometimes it doesn't come out as like obvious depression or anxiety. It's more irritable and temper tantrums and defiance. And then panic attacks, a racing heart and dizziness and overwhelming fear of death, fight, flight, or freeze. Okay. So now we want to look at anxiety and depression as it occurs across the lifespan. As a child psychologist, I'm taking more of the approach from parents of younger kids, and younger kids all the way through adolescence. And Aurora is going to look more at young adulthood and into later adulthood. Just so I know, is there anyone here that's considered maybe a minor, or have a parent with someone who is a minor? Nice to meet you. Okay, great. So some of the information I present might not be fully pertinent, but it might be at some point for adults who have families in the future or other kids. I think this information can be used for all families. So we want to talk about family functioning before we get into individual lifespan. So we know that spina bifida disrupts at least some part of the family dynamics. And we call that dysfunction resiliency. We do know, as Diane mentioned the word resiliency earlier, that individuals with spina bifida are very resilient. A lot of you have dealt with a lot and managed a lot in your life, and as a result, a lot of people come out stronger and are able to manage a lot of difficulties in their life, and so much more than the general population and more than other chronic medical disorders too, where we are really, it's a real strength for our families. So, but there does tend to be more stress and dysfunction within the family. And then that stress and dysfunction can change throughout the lifespan. So maybe something that we were managing in school-age children is going to change and look completely different for when the child turns into the adolescent years. Okay, we're managing different things. Another protective factor of the family functioning within spina bifida families is there's generally less conflict in the adolescent years. So, and that's including in neurotypical families, other chronic illnesses, and so a lot of that can be attributed to that resiliency factor, where adolescents really have learned to become resilient and independent, and have worked hard through their life. So they're not having a lot of that typical adolescent challenge that maybe other families are managing.
Doesn't mean they're not still adolescents.
That's right.
Yeah. We've all been there. I think everyone in here has been there. Yes. Okay.
So as we're thinking about parenting styles that are effective versus maybe aren't as effective, we think about responsive parenting versus intrusive parenting. And this is especially difficult for families and parents and caregivers of children with spina bifida, because individuals with spina bifida do require a lot of care and management and teaching, and that can be sometimes difficult for the family to know that balance, that fine balance between how much do I do versus how much do I foster and try and help that child develop. So responsive parenting is using a lot of empathy, setting expectations clearly, not using a lot of shame-based parenting or chastising, helping and modeling these different developmental skills and areas of life. Whereas intrusive or overprotective parenting tends to be more taking on everything, using a lot of maybe shame or excessive discipline. And we know that with responsive parenting, it's associated with a lot of adaptive coping. I heard self-esteem earlier, so developing a child's self-esteem, helping them problem solve. Whereas intrusive parenting is really associated more with lower decision making, more anxiety and depression, we know, and adjustment difficulties. So just some ideas on what positive parenting or responsive parenting might look like. We are focusing on nurturing the wanted behaviors while also not paying so much attention to the unwanted behaviors. So not punishment, but empathy, love, nurture, guidance. And this type of parenting strategy really works because we're focusing more on what we want the child to do rather than the negative behaviors or spending so much time in conflict. It helps encourage personal development, just a very crucial skill in the life of a person with spina bifida, to teach them how to be as independent as possible straight from the time they're born. There are developmentally appropriate skills that we're teaching along the way that we'll talk about here. Positive parenting helps build social and emotional resiliency. lowers childhood depression, and it improves the self-esteem that's very important quality to have as well. So just some tips for if we're parenting a younger child or any person with spina bifida and otherwise. These are just general parenting tips, but especially is very effective in that idea that we're hoping for independence. And so we're present with the child. We're, in the early years, we're playing alongside of them. We're monitoring what they're doing and describing what they're doing and playing with them. In older years, we're going to conferences with them. We're taking them to trips and being part of their life and really showing an invested interest. We're leading by example, not showing or rescuing or over accommodating, but providing appropriate guidance when needed. And we're empathizing. So yeah, this is really hard to do, and I get it. And by doing this and mastering these skills, we're gonna, really hope for positive outcomes and a lot of success and strength. Setting clear and consistent boundaries is really important. So children with spina bifida academically tend to struggle with abstract language. So being too vague with a younger child can be confusing. It can be frustrating because they're not understanding what we're saying. So very clearly just describing what we want that child to be doing. And then follow through is important. So if we set a boundary with this child or older person, then that child knows kind of what we're expecting them to do and what we will be prepared to follow through with. We want to consider the child's skills and developmental level. Providing too inappropriate of expectations where the child's not able to do that is going to end in frustration. Positive reinforcement over punishment is really important. So as we think about maybe how are we implementing a consistent bowel program or calf program, how do we do that? How do we track that? So maybe setting up something in the early years for successful approaches to that, which can be earning tokens or earning time with us and picking dinner that night or dessert after dinner. So just being very clear about here's what the expectation is and here's what you're going to earn if we can follow through with that. And all of these skills, these parenting strategies really create trust within the relationship, and trust builds self-esteem. So here are some other things that we can use for a younger child. With that abstract language deficit, it's going to be difficult for maybe someone to explain their own emotions. So starting with an emotion chart where we can just teach basic emotions with pictures. Using positive language can be helpful. So not focusing on that, no, don't do that, stop hitting, I can't hear you. So we're using language that's more designed to get them to do what we want them to do. And this pride skills, this comes from parent-child interaction therapy, which is a therapy that is designed for kids who are under 7 years old, and it really can be effective to improve the parent-child relationship and then teach the parent really specific ways of following through and setting those clear expectations. We want to touch on sibling adjustment. This is very important and often neglected, as if, especially if you have a sibling in the family that might not have a medical need or another need that requires so much attention, that sometimes these siblings can feel left out. They can feel neglected sometimes. And so we know that siblings of individuals with spina bifida often report that they have negative feelings around the health and safety of their sibling. They have distress, especially if the sibling is being targeted, discriminated, or bullied. They have a lot of sadness sometimes reported that they can't do more physically or engage in physical interactions with their sibling. But we know from research that positive attributes of these siblings are an increased empathy for the sibling. So just an overall acceptance and ability to know where that sibling is and be there for the sibling, and then also greater appreciation for their own physical abilities and just general skills and attributes that they have. So we recommend spending as much, if you have another sibling at home or you yourself have another sibling coming, then spending as much time, individual time with that child, helping them foster their own interests and encouraging sibling advocacy. So maybe making that sibling a part of that child's care team. We do offer SIB shops, which is a national program that allows the sibling to get together with other peers, have fun. And so we offer that at the Perelman Center through Children's. That's about once or twice a month, and it's on a Saturday. They have fun. So if you are interested in that, recommend calling and requesting some information on that. So just to talk briefly through the lifespan of these different age groups. So we have the infant and toddler years, which is going to be less focused on the actual individual in terms of mental health and more focused on the time to help the new parent acclimate to, what we need to do to get that child to reach their full potential. It is important that the parent is screened for their own depression and anxiety and trauma. Checking in on your own mental health and as a parent and getting help and support in areas that way. It's a time for parents to learn more about Spina Bifida and getting connected in the community, their local Spina Bifida chapters, or engaging in the walk and roll. Getting connected with other families and parent-to-parent supports is important. Focusing on that child attachment that I just talked about is really important. So learning effective positive parenting strategies is helpful. Connecting the family to the early interventions in your state. So usually states will have services provided through the state before the child's 3. Here in Ohio, it's Help Me Grow. Kentucky, it's First Steps. Virginia's Birth to 3. And those are often helpful services to have those individuals part of your care team. It's never too early, like I mentioned earlier, that we're working on resiliency and independence. So developmentally appropriate steps of helping the child learn different chores, even if it's cleaning up 2 of their blocks that are on the floor, or helping with housework alongside of us. So we're cleaning windows and that child's helping right next to me. And then we're encouraging appropriate play with other children and social development by getting them as connected as possible. These are all pulled from the Spina Bifida Association mental health guidelines, which are very helpful there. We recommend reading through those that do talk about guidelines throughout the lifespan. Preschool age, a big step here is getting the family connected to school services. So once the child turns 3, the school services start through the district through either an IEP or other form of special education support. And we're encouraging participation in preschool, where those 2 years can be really helpful in learning social skills and independence outside of the home. We're referring to social skills training and planning some play dates. We are hoping to assess social behavioral and psychological development. So if the family is starting to be concerned about disruptive behavior or mental health concerns, we're going to connect that family to parent-child therapy if needed. And really important to keep consistent with schedules, routines. This will help foster that independence. Okay, so trying to keep everything as predictable as possible within the family. School age is a really important period of development. It's the first time sometimes that the child's being put in regular contact with other children, which can be very scary. It's maybe sometimes the first time the child is starting to see differences in themselves compared to other people. So keeping that in mind, this is oftentimes where we start to see decreased self-esteem or self-worth. So we're really being vigilant in getting that child connected to the appropriate services and resources. Friendships become important. We want them to feel connected to other people, and that they do belong, because everyone belongs, and it's just sometimes easy to avoid, especially if there's a lot of anxiety about something, and then the avoidance starts to impact our own anxious thoughts of, I'm not worth it, no one likes me, I'm going to stay out of this. And then adolescence is a really also, like Aurora mentioned, a very stressful time for everyone. It's a period of a lot of physical and mental, emotional growth and social changes. It's a time where we're developing our own personality and our own interests of what maybe we want to do with our lives. It's when we're starting to have more opportunities for dating or social connections, as which can be stressful, especially dating, and can impact overall mental health. And then there's a high focus here, really high focus, where we're wanting to foster that independence with the knowledge that the child's transitioning to adulthood soon. So at 14, and in the school district, part of the IEP process is going to be talking through transition services that the child's going to need as we start to prepare for adulthood. And a lot of families don't sometimes realize that the IEP can be used until the child turns 22. And so we can sometimes delay graduation there if we still need some more work and supports in place. All right, so now we're going to talk about some more causes of anxiety and depression. We have physical causes. Of course, the hydrocephalus and the shunt failure. I heard shoe dropping and the what ifs. This can kind of get into that realm where it's just maybe feelings of hopelessness or feelings of just chronic worry where we don't know maybe what might happen. Traumatic brain injury, sometimes involving hydrocephalus, can impact the brain structure and neurochemical balance. Oftentimes, neurochemical imbalances can just be hereditary, and with everyone, we just might have predisposition to anxiety and depression. And then other physical health issues like adrenal, thyroid issues, obesity can be a big one where maybe we're not as active as we want to be, and that can make us have other physical health issues and mental health issues. Medical care causes of anxiety or contributing factors. Just the amount of time that takes with the bowel and bladder management program. So a lack of real privacy, a feeling like I'm different, especially in the school setting, the time requirements, sometimes a lot of pain involved, the incontinence and embarrassment maybe of being in a social situation, which can lead to increased isolation. And then a resistance to sometimes following the bowel program, especially in adolescence. We are starting to become more independent individuals, and we sometimes in adolescence don't want to hear from our caregivers on what to do. And so we sometimes want to do it ourselves, and sometimes that's tricky and difficult to follow that completely at that age. Ambulation can be difficult. So we know that children and adolescents with spina bifida are less active generally than the general population, which less activity in general can impact our mood and anxiety. Barriers due to mobility and incontinence. So feeling like I can't go where I want to go, I can't do what I want to do, can really impact how we feel. This idea of health problems and long-term trauma. So the guessing game, the always waiting for the shoe to drop, the feeling like we're always on pins and needles can be hard. And then pain, just a lot of pain in general is associated with anxiety, depression, especially in females generally. And then, so thinking about the pain is often co-occurring. So we want to regularly screen for pain. We want to give the individual knowledge about how to manage that pain, and considering alternatives. Like, heard coming in some different alternatives for someone doing some pain management, and nothing's worked, and that can be really frustrating. And I think just having to go down the list of something, okay, well, this isn't working, so just keep trying. Okay, we have a lot of social emotional contributing factors to anxiety and depression, like that self-esteem I heard, not feeling normal. Social interactions. So children and adolescents with spina bifida sometimes are feeling, they sometimes present as immature or too passive, or they have fewer friends. And that we know that they sometimes misunderstand the quality of friendships. So they think sometimes that friendships are more cohesive or together or close than the other person might feel. There's that fear of embarrassment and being out. So, going to sleepovers at this age, and how do I manage care there? So that can be very stressful. That loneliness that I heard, that's a common feeling of I don't have anyone, or I feel so alone with this. And that's why connecting with groups like this and can be really powerful. Adolescents with spina bifida often date less, and there is increased risk of bullying in this population. And sometimes with that knowledge of the wallflower I talked about earlier, just not being able to maybe talk about it with others or advocate for ourselves, just not really knowing what to do with that. So we always want to check in if there's any mistreatment among these youth. Feelings of being overly enmeshed with caregivers, especially maybe intrusive parenting, or caregivers have to do a lot, and so sometimes not knowing, like, if I can do that myself, or having the skills or the belief in myself, and maybe focusing too much of our attention on having our caregivers help us. Other social emotional causes, so fear of travel, getting too far away from our primary care or our neurosurgeon for fear of something happening on our trip, and that keeps us isolated, and which can contribute to anxiety and depression. There's just sometimes a lack of medical care, especially if we're living in rural areas, and psychological treatments. We did, for preparing this presentation, there's just astoundingly little research on specific mental health treatments in spina bifida population. So that can be very frustrating, making us feel even more different and alone. Lack of access to accommodations and support. So I've heard kids talk about, my school doesn't believe me that I have to miss so much school. And that's incredibly frustrating. So they don't provide what I need at school or at work. And so there's just a lot of misinformation and in the community, where there's ignorance, and that needs to be taught and helped with. Daily living skills and decision making, especially as we near adolescence and adulthood, can be difficult, especially if we are overly enmeshed with our caregiver or depending on them to do too much for us. And just briefly, I want to talk about, we could do a whole presentation on the psychological and neuropsychological profile of a child or adolescent with anxiety or with spina bifida, but common ones are overall average IQ intelligence, but sometimes on the lower end, usually a higher skill with verbal IQ than nonverbal IQ. So there is some thought that maybe there is a nonverbal learning disability within this population. And nonverbal learning disabilities really impact our social skills, understanding nuances of nonverbal input that's coming to us and knowing how to respond to that. Language is a strength. We are often have a lot of language in this population, but we also can be somewhat tangential, off topic. And again, we sometimes lack that ability to understand abstract language. Academic struggles can really impact our overall self-worth and self-esteem, increasing anxiety, but definitely some difficulties with reading comprehension, arithmetic, and writing assignments. Executive functioning skills go hand in hand with this often, where we struggle sometimes with organization and memory, inhibiting ourselves, decision-making, executive functioning skills being what helps us get through a task. How do we stay online long enough to start and stop a task? And that can be incredibly difficult to start something and complete it. So sometimes this population do look like they might have inattention or ADHD, but sometimes that's just, it's difficult getting on the task and getting started. So we have to recognize that we might need more support getting on there, instead of just saying, oh, that child's not paying attention, and oh, they're just ADHD. So, you know, and sometimes treating that or supporting that isn't what we need to do. We just need a little bit more guidance and support to get on there. And this can often be confused, you know, with the attention with children with depression, because the child looks unmotivated because they don't know how to start. And it's not depression. It's more, what do I need help here. I need guidance. I need modeling. And once they're on task, it goes better. So just knowing that it might not be depression. We have to really look at all these other factors. And then just visual motor and motor planning, other motor skills. Sometimes that fine motor, especially with shunted hydrocephalus, is difficult. And so knowing that some supports around that are going to be helpful. I think, yes, I think just being able to practice that through setting up a lot of visual supports for the child and practice and a lot of modeling. And so helping them through a situation that might have a lot of nonverbal components to it, and while using their strengths with verbal skills, talking through it while we're, you know, so I'm thinking about, like, it might be difficult to do a full load of laundry, for instance, right? And so talking through the steps, but also having something up there so we can talk about each step here, and until we master each step. Sometimes we'll work backwards while, you know, the last step is hitting the button of the dryer, right? And then we're helping them go back and until they're doing all of the steps, including putting the load in and that kind of thing. So just a lot of modeling, I think, a lot of encouragement and praise and trial and error. Assessing social situations can be helpful. Of maybe something that didn't go so well, we can think through what didn't go well. Let's really think about how to process this situation for the future. Role play, I think just a lot of working on individual skills that we're seeing are deficits with the caregivers. Anything on that?
Yeah, I think the only thing I might add is similarly, the role playing is probably the biggest thing that I think about for younger kids or even adults. Let's say you have an adult and they're really struggling. Gosh, I just can't get a date to go well, right? That's actually where, you know, the adult version of Nick, not your adult, but like the person who works with adults would be great, because then you could kind of practice the reciprocity and even practice like certain facial expressions, or like, you know, the therapist could pretend to be on their phone, you know, while talking, like, oh, what does that mean? How do you feel when someone's doing that? Talking through those kinds of things can be helpful. And of course, parents and friends can do that kind of thing, but I think it helps to have that therapist or someone to kind of walk you through that and practice some of that back and forth. You know, I've seen some of my even adult patients do things like practicing the conversation through simple exercises of, like, you have something that you pass back and forth, right? I'm going to say something. Okay, now I'm going to respond. We were talking, my husband does improv, and a lot of dating or relationships is being able to respond and ask questions. And so building that skill, it's not that you don't have those skills, but building them in a way that builds a connection can be really helpful. And all of us need that, right? Not everyone is born with an intuitive sense of how to connect with people. So it's not something to feel ashamed of or to be like, oh, I'm less than because I can't do this. It is something I believe that can be learned. So any other questions? Yeah, for
just what age? You talked about adolescents and then adults, kind of like my daughter's 14. So is she too young to go to adult clinic or adult?
oh, she could see if there, yeah. So if she's 14, she would probably see someone, I mean, like Dr. Hartley, who focuses on child and adolescent therapy. And then once she turns 18, typically 18. I do see some teenagers as an adult practitioner, but that's mainly because I did family medicine as well, so I'm pretty comfortable with kids. Yeah.
And we sometimes see adults that we've maybe treated in the past and who we're still determining the next level of care. So we'll see them maybe past 18.
Other questions?
When you were talking about pointing out to them when a social situation they need to go out, the best way to approach that without hurting yourself.
I like to use material that's not about the person, maybe a movie or a book or a story that has a similar situation. So thinking back to a lot of Disney movies are really good with this, and thinking about, oh, this person got their feelings hurt. What do you think happened? Or what could happen next? What could this person do to resolve the situation? And then as we get better at that, at identifying those situations outside of ourselves, we can start to do what's called a social autopsy, which is taking the situation, and you can find them online all over the place, but just describing the situation very matter-of-factly, concrete. What went well, what didn't go so well. And so just gathering clues and kind of taking that approach where we're detective working here and making sure that we all need help with social skills. And yeah, so thinking like, let's just work on this, and it's okay if it's not perfect. And so a lot of empathy there. So now we talk about how do we manage this, and different go through the different categories that I talked about before. But first, thinking about medical needs, a big one is understanding a really consistent bowel and bladder program, usually that the child and adolescent is able to follow and understand. By teaching toilet independence, it just has a lot of nice after effects like self-esteem, mobility, participation in things, avoiding that embarrassment and isolation. And this often requires empathic listening, trial and error, finding what works. In the school age, this is really important to connect with the school staff so that they are able to help with this and know the steps that go into this, so the child's not feeling like they're alone there at school. And then talking with your healthcare provider can be helpful to talk through different strategies and programs. Pain management, physical therapy. Younger kids were thinking about protecting their skin and braces and burns and a lot of sunburns. So, and then we're always teaching about safety awareness. One thing to consider is mobility safety and also emotional safety. So this population does sometimes have a higher risk of emotional, sexual, or physical abuse. And so understanding what that looks like and how we can protect ourselves. And then we're always fostering independence and safety. I could talk about a whole hour with IEP and 504 plan supports, but this is a great resource that the Spina Bifida Association has provided to help you through that process. But a lot of times families do feel like maybe not on the same page with their school. And so I put this is a great resource, especially for anxiety accommodations that can be considered in the IEP. 3 or 4 pages worth of really good stuff there. And then just, your child most likely will qualify for an IEP. So if you do have questions with that, we have great social workers at Cincinnati Childrens who can help that process, or talking to your pediatrician if you have any concerns. We can connect you with education advocates who can talk to the school on your behalf if you're not satisfied with the care that your child's receiving in the school. Connecting with others is important. So spending time with family and friends, arranging play dates, arranging special events, getting connected with a group of people that have your own interests. So a team, maybe a hobby. Joining closed or private social media groups can be helpful to start to understand you're not alone, and that there are other people out there who want to get to know you and who have been in your shoes and who can connect with you. More locally, getting involved here with the Spina Bifida Coalition. I know you all have some really nice events there. And then summer camps in childhood can be important. The walk and roll. Social skills groups, so more of a formal group, can be helpful. So talking to the school, if that's available through them, or the community. And then if there is bullying, this is a great resource online that can help talk about that and help you with some strategies there. Other self-care, so nutrition. We want to think about weight gain, constipation, osteoporosis. So here are some tips for the nutrition. Just making healthy eating choices. Sleep is really important. It helps the body recover and reset. Lack of sleep really impacts mental health. So getting to bed at a regular time, and there's some tips there too. And then getting active is really important. Exercise can be the best thing that we can do. So we recommend 60 minutes a day of physical activity. That can include, for younger kids, crawling through obstacles, obstacle course, or physical activity with our friend, joining a sports team, or lifting weights, dancing, aquatic therapy. If you're not ready to do 60 minutes, then start where you're at, 5 to 10 minutes, and work from there. Other really great self-care techniques: music art therapy is really nice. Journaling, so getting all of those anxious thoughts out on paper and being able to, get it from here to there. That's often the battle, is it's just ruminating, and it needs to be somewhere. Mindfulness and meditation are really helpful to just be in the moment and learn how to let anxiety pass and not overtake us. Yoga and deep breathing. This 5-finger breathing is really nice that I teach my kids. So breathing in on your way up and out on your way down, just doing that 5 fingers. These are some.
I was just gonna ask, anyone do any mindfulness here, or like practice meditation or yoga? Yeah. Anyone like a journal? Not so much journal. Someone. Okay. Any music lovers? I like a lot of my folks just love listening to music to decompress. Yeah. Okay, cool.
Any other coping skills that you use that's not up here? Yeah. Yeah. Do you want to describe that? All right. Yeah, that'd be great.
Do you want me to bring you a microphone?
Oh, okay.
Talk about anxiety, right?
There's a few different versions of it, but one of my favorites is and I might get it wrong in the moment, I apologize. But the one that I use a lot is, you look around the room and you look at 5 things you can see. I think it's 4 you can hear. 3, or I gotten that backwards. 2 you can smell, and one thing you can taste, and it just it gets you to really focus and kind of calms you down, gets you to think on something except what you're about. Really helps. And then I also love the it's I don't know the official name for it, but it's you look around the room and you find things that are each color of the rainbow. So or the
Oh, I haven't heard of that one. That's really great. Love that. Thanks for sharing.
Yes, I love the 5, 4, 3, 2, 1. Thanks for sharing that. It's one of my favorites.
All right, and here's some book options for kind of younger kids. So I know there's books out there for adults. These are the ones I'm familiar with. And then we'll talk quickly about the types of therapy that we can think about. For younger kids, we're really focusing more on fostering that positive parenting. So PCIT I mentioned earlier, and play therapy. For older kids and adolescents, even starting in school age, we can often do a big one is cognitive behavioral therapy, where we're really focusing on understanding how thoughts and behaviors and emotions are all impacting each other. And so they often, one impacts the other. And then acceptance and commitment therapy. So accepting our thoughts, not judging them. So a lot of mindfulness and meditation based in that. Dialectical behavioral therapy. So really understanding how to manage intense thoughts. Oftentimes this is used sometimes for kids with like bipolar who have a lot of intensive thoughts. So there's generally a group component of DBT, so we can get kids together and learn from each other. For trauma, we use a lot of eye movement desensitization and reprocessing therapy. So while we're reliving the trauma, we're focusing our eyes on different places. So it's a little bit like mindfulness and and grounding ourselves so that we can reprocess some of that trauma. And then psychodynamic is kind of more rare, but talking about like the intrinsic feelings of what comes up. So in our own self and how maybe those came to be in our life. Art and music therapy can be really helpful. Adaptive horseback riding, it can be really, really nice. Family therapy, if there's more group family conflict. And then group therapy is a really, I think, important one, especially in this population where we sometimes feel isolated and alone. Getting with a therapist who can be, can learn from our peers. Remember, therapy is not a quick fix, but it can be a really rewarding journey where we start to learn more about ourselves and how to cope. All right, getting help. We sometimes just have to ask ourselves, especially as parents, is this something serious? Is this a phase? All kids go through trials, tribulations, but how much is this impacting the child? So oftentimes asking our healthcare team or teachers can be helpful and learn from their observations. Asking for referrals if you do feel it's time to maybe find a therapist. So counselors can include clinical psychologists, school psychologists, psychiatrists can do some therapy work and medication management. Social workers can help. This is a good resource. This organization does list providers that are in your area. Our social work department and these Childrens is really helpful of looking in your area and helping you find some providers who would be appropriate. And that's the thing, you want appropriate. So this is sometimes a really difficult process in finding a helpful therapist. And it is okay to end a relationship with your therapist if it's not working. And that can happen pretty quickly. If you feel like it's not a good fit, we don't get our feelings hurt. We understand that it is about the process for you. And so it's okay to stop. So questions, do you use evidence-based approaches? That's a big one, I think, to ask. And do you involve the parents, or what's the process for therapy? Okay.
Same goes for your doctors. If you don't feel like it's a good fit, it's okay. I'm not offended.
For time, maybe
Sure.
leave this at the end, or if we do have time.
For the video, we'll do it.
Okay.
Great. So I'll talk a little bit about the transition to adulthood, because I think this is a time that really, I mean, gosh, it's stressful for every human on the planet, right? There's a lot of changes. Are you going to a new school? Are you continuing your education through high school or a vocational program? There's a lot of change that happens and a lot of new expectations. Suddenly you're 18 or 22 and it's like, okay, now what? But this can be a time too where mental health issues present themselves. Our early 20s is probably one of the most common times for people across the population to be diagnosed with anxiety. And it's also a time where the brain is still changing. You know, I tell a lot of my patients who come in that we don't really think the adult brain now matures fully until age 25. There's mild variations potentially between men and women, but I would say in my folks across the spectrum, with intellectual or developmental disabilities, I feel like sometimes that span can be a little bit longer. So it's okay to give yourself a little bit of grace. Be like, okay, my brain is still growing and changing. And so I need to keep bringing that awareness to where I am in life. I think we've talked a lot about the different stressors, but coming into thinking about how am I going to manage finances? How am I going to find a partner in life? Do I want a partner in life? How important is that to me? And then of course, you know, my job is helping people transition from their pediatric care to the adult world. And there's a lot of differences, right? Children's has a lot of services, or hopefully if you're coming from another state, you're at maybe a large center that also does have similar services. And the adult world is just starting to, you know, get their stuff in order. You know, we're working really hard to make things better, but we try to put round pegs in square holes, and that doesn't work very well for a lot of folks. I think we talked a bit about this. The thing I'll highlight is that there can be just a lot of burden with the frequent medical visits and care, especially as we go into adulthood, and maybe parents or caregivers are no longer able to provide that same level of care. Like families change, right? People get older, people pass away. Not everyone has a robust family or has somebody who can support you. So that can be really complex, and you can have to have conversations early on about advanced care directives, who's going to be involved in your care, and that can be very stressful for everyone. So I do encourage having those conversations early in general. And I think Nick addressed a lot of these other things on here. One thing that I don't think we have mentioned though is we've mentioned that individuals with spina bifida may have higher rates of depression and anxiety based on the few studies we do have, but we have 0 studies on, you know, people of color or other minorities who are impacted by this condition. So we know that they are already at greater risk for medical complications and lack of support. So it would not shock me if they are at higher risk for depression and anxiety. So making sure our spaces are inclusive. Important to know that your child or young adult may have gone through the whole period of childhood without maybe being caught, quote unquote, not caught as you're in trouble, but, you know, caught by a screening. Maybe you took a test on depression, but it didn't really apply to you because your symptoms were a little bit different. Maybe, like I talked about, that irritability, or maybe you just, you know, had trouble getting the ball rolling and just didn't feel very involved in your own life. And so it's really important when you're going in with your doctors, with your care providers, that hopefully they're asking you, how are you doing? How are your spirits? How are you feeling? And if they're not, that may be a good clue. Looking for, not looking for a new person, but saying, hey, you know, I'm a little concerned. My son or daughter or sister, sibling, whoever is, they're a little different than they used to be. Yes.
I think that when you talk about that wallflower impact too, that sometimes people with spina bifida want to appear better than they are because they don't want problems with holes. So they say, I'm fine, it's good,
right,
everything's great.
Yeah, but you know what? That's true of all of my patients, right? No one wants to really come in. You know, I take care of people around pregnancy, and a lot of OCD shows up in pregnancy and postpartum, and no one wants to tell me that they're having these bad thoughts, and no one wants to talk about it. So I usually say, I try to lay it out like, hey, you know, it's normal to feel anxious. I would be surprised if you told me you're not. feeling anxious or depressed sometimes. And here's what we'll do if, you know, if those thoughts do come up. But absolutely. So that's why I think that high level of suspicion is so important, talking to the families as a whole, of course, with permission from the individual who's involved, and then talking as a group. So I like to talk about prevention because I don't think we talk about this enough in mental health and psychiatry, but I think Nick listed a lot of the things that we can do to prevent depression and anxiety. But really, again, like I always say, make whoever it is, make the individual your consultant, right? This is what I like to do in therapy, is just really say, hey, what's the biggest issue like going on for you right now? What can we do to make things a little bit better? Maybe you're worrying about the bowel or bladder schedule, but they're like, Jim in school is just such a jerk to me, but I still kind of like him and I don't know what to do, you know? So focus on that for a moment, you know, and come back to the other things. And even helping put language to what our strengths are and weaknesses are, you know, I think as a parent, you know, as my kid gets older, I think I'm going to have to sometimes be like, yeah, you know, I'm just not that good at putting the laundry away, but I'm pretty good at doing the laundry. Like I get it done, but I'm not that good at putting it away. Like it's okay, you know, give language to these things and be honest about it, as opposed to giving those expectations of perfection. And that's what I mean by identify strengths and weaknesses, and then talk about what you're really good at. And maybe laundry is a bad example, but I think you know what I mean.
I think that provides a lot of great empathy, and what we were talking about earlier, you know, sharing with our child, being open, and understanding that I'm not perfect. I'm not expecting you to be perfect, and so having that connection.
Yeah, awesome. So for mild to moderate depression, and your doctor should be the one to tell you like what they think it is. Do they think it's in the mild or moderate range, or your therapist? And so there's a lot of, if you hear this term, you might hear the term behavioral activation. Fancy way of saying, hey, get your body and mind moving with something, doing a routine, going out, even if you don't feel like it. And that actually triggers our neurons to light up. If it's something we used to enjoy, with time, the idea is we can like re-spark that connection. So getting those things early on, like if you start to notice, oh, I'm falling off, I'm not doing the things that I used to do. Okay, even though it really sucks, we're gonna do it as if it were taking a medicine, right? It's just as important as taking a pill is to like get up and go to the grocery store, or go to your hippotherapy, or hang out with your friend, or call them. Increasing physical activity, particularly for both anxiety and depression, can be hugely beneficial. And again, it's that motivation hurdle that you have to get over, which is programming it in if you can, and understanding that it is like part of the medicine. I think that's, you know, it's not something you just force someone to do. I can't force anyone to exercise, right? And then how many of you have heard about light therapy? Okay, awesome. Anyone think that they deal with seasonal affective disorder? Me too. So my favorite lamp is the Verilux Happy Light. They can be pretty cheap. You can take them, there's portable ones. And what you're looking for is something that has 10,000 lumens. And using it for about 30 minutes a day. You don't have to stare at it, just next to you. And using it daily is key though. You can't just use it kind of as needed, or use it every day. And it's on par with taking an antidepressant for 4 to 5 weeks in some studies. So if you're already doing all of these things, perhaps you might, and engaged in therapy, of course, you might consider medication if, gosh, we're still just not seeing improvement. If it's moderate to severe, especially if you're having those thoughts of just life isn't worth it, I don't want to be here, then all the other things we just talked about, and seeking a professional opinion. That can be your primary care doctor. They should be well equipped to start thinking about it with you and deciding or helping you decide if you need a psychiatrist. I always say rule out medical causes. Can't tell you how many people have come in to see me with a UTI or horrible constipation and having kind of worsening irritability or poor sleep or some other kind of manifestation, or ear infections are pretty common as well. And then often if it's so severe that you're having those thoughts, that's when I tend to say, okay, medication probably is warranted. And that's when you would have that conversation with your doctor about what's best for you. We won't go into details of the types of medications that you've probably heard of. Antidepressants, anti-anxiety medications, which can be the same. And then mood stabilizers are a different class, but they can often boost the use of those other medicines. In rare cases, again, especially if you might have that more severe depression we talked about earlier, you might be talking to your doctor about a procedure like electroconvulsive therapy or transmagnetic stimulation. But those would be something where an expert would talk you through why are they mentioning that? Why are they bringing that up to you? So I'll briefly tell you a little bit more about Sally. So Sally and I got to continue to meet and she started to feel a little bit better. We had started an antidepressant, anti-anxiety medication, and some things were better. So work was going better. She was getting out of bed. But as we talked more and more, we realized she was really just unhappy in her relationship. Turned out her partner was maybe not always kind to her, maybe put her down at times verbally, not physically abusive, thankfully, but just not very kind or supportive. And without me doing anything, Sally decided to leave that relationship and came back to see me like 3 or 4 months later and was like, hey, I'm doing great. And I started dating someone new and they're very kind and supportive. And I feel like I kind of figured some things out. And so we didn't end up needing to continue that medication very long. I think it turned out that there was a social root. So this is just a really important example of how life is complicated, right? Someone can come in and they can look like one thing and tell me all the things, and then it can actually turn out, you know what? No, there was something bigger going on, but they weren't quite able to see it yet, but they figured it out. Not that I think the medicine was a bad thing. I think there were some symptoms there, but the relationship ended up being a big piece of it. So we talked a little bit about anxiety treatment. A lot of it's the same in adulthood. It doesn't change that much. So doing specific therapies, Nick mentioned CBT and mindfulness and acceptance and commitment therapy. I'm also a really huge advocate, again, for anything that gets us moving our bodies with our breath, anything that links motion with breath. You don't have to call it yoga. You don't have to call it Tai Chi. You can do some very simple exercises and just breathe with those movements, lifting weights, right? We all need strong arms and legs if our legs are working fully. To lift weights and breathe can be just as good as yoga and some of these other things if that's not your cup of tea. And then I really think that social connection, support groups, and maybe group therapy, if it's accessible to you, can be really helpful as well. And then again, when do you want to seek help? Gosh, if your panic attacks are coming more than once a week, or they're just so distressing that when they do come, they set your whole day off, okay, time to maybe come see someone or talk to someone more about it. And then we talked about that anxiety and depression often go hand in hand. If you're suffering from both, yeah, talk to your doctor about it. And then again, always pay attention to the medical causes. We can ignore those sometimes and think that it's all mental, but the body and the mind are deeply linked. And if it's more severe, then there's a lot of different ways that we can try to treat anxiety. Yes. Oh, yes. Yes, I think I thought we had that on another slide, but yes, emotional support animals are wonderful. And I definitely support them. There's a lot of evidence for decreasing anxiety and stress. So if you're a cat lover, dog lover, lizard lover, snake lover, whatever is your, animal of choice. I'm always happy to write those letters for folks. And I tell people, I'm trying to be aware of the time. I know we're going a little bit over here. I always tell folks, you don't need to pay money. Someone tells you that you need to pay money for like a certification for your emotional support animal, they are scamming you. Do not pay money. All you need is a letter from your doctor, and that's it. And then just to be mindful of time, because I know people might need to go soon. I was going to talk a little bit about PTSD, but will they have access to these slides?
Recording.
Okay. Do people have time?
I got my 11.
Is it okay if I talk about PTSD for a moment? Okay. So I tried to find if there had been any clear research for individuals with spina bifida on PTSD, and I'll be honest, I didn't find any papers. But in the general population, 6% across the lifespan of individuals do experience this. You've probably heard of some of the symptoms. I think most of us think of people returning from war, but more and more we recognize that people who've experienced extreme medical procedures or surgeries, for example, have been in accidents, or families who've experienced their loved one or their child coming near death, all can be, and that's perceived that way, not just, doesn't mean that it has objectively been near death. Those can all result in PTSD. And usually these symptoms occur 3 months after the event, or remain 3 months after the event. Otherwise, we're in an acute stress kind of period. But you can feel really on edge, feel like you're constantly looking over your shoulder, or let's say it's time to go, let's say it was a medical emergency that happened. And now you really just can't even drive past the hospital. You don't want to go near it, or you don't want to go to your doctor's appointment. Maybe you're really irritable or jumpy, not sleeping well, or having nightmares about what happened. And a negative outlook on life, a difficulty imagining a good future. And that can all sound a lot like a depression, can't it? And you can have depression with that as well. So really, treatment involves hopefully being involved with a team of physicians and therapists who take a trauma-informed approach. This means that they are going to be aware that it may be very difficult for you to process certain information or certain exams, for example, depending on the nature of the trauma, and that they are going to have steps to walk you through that and ways to make it more comfortable. And that they'll use language that's appropriate as well, and always ask for consent. We should always be asking for consent, but being extra cautious around those things. And I think Childrens does this really well, and UC is getting better. Some therapies we use in adults are cognitive processing therapy. So there's a stress center at UC. I always think it should be called the Resilience Center, not the Stress Center, but they are psychologists who treat trauma particularly. And cognitive processing therapy is similar to CBT, but it asks you to write an account of what happened and why you think it happened. And then you examine what occurred and talk through how you think now. How do you think about life in general now because of what happened to you? And we call them stuck points. Perhaps I believe, well, I'm never going to get better, or anytime I go to the hospital, I'm going to be stuck there for months, or I'm not going to be able to regain XYZ skill. And so we look at those thoughts and we work through them, and we come up with ways of thinking that are actually more adaptable or realistic, because those thoughts are stuck in the negative patterns. Sometimes medication is indicated, but not always. So this goes back to what I was saying, that children and adults with life-threatening illnesses can experience the diagnosis and treatment as traumatic. And it doesn't matter if the objective prognosis is actually life-threatening, but a parent or even a child, once they become aware of their condition, can experience that as traumatic, like, oh gosh, so I've been near death since birth, or I could have all these kinds of complications. That can be very distressing. So we always want to include our families. We want to monitor the level of distress and provide that emotional support. And then be very clear about treatment. Not, we don't live in an era anymore where we don't include children or adults in their treatment, right? And stand behind closed doors. We should use open and clear language. This is what the problem is, and not in medical language, obviously. In medical language, we can all understand. And this is what we're going to do. And this is our expected outcome or our hope. And these are the risks. Having that conversation with everyone. I wanted to talk briefly. So when this connects to when people are in the hospital, and when they're out of the hospital, but we all have our phones with us all the time. So there are a lot of apps out there now. Some of these you may have heard of before. But I really like Headspace and I really like Calm. Calm has a really nice, the daily move, I think it's called. It's about 7 minutes of just moving, and it can be adapted to being in a wheelchair. It can be adapted to different limbs being able to be moved. And it is a way to engage in mindfulness that maybe doesn't feel like mindfulness, with a capital M, And then Headspace also has ones for children and families, which I think can be really helpful. And then Insight Timer has really short ones on anxiety, 2 to 3 minutes of just breathing, and having someone kind of walk you through what might be stressful. And then a newer one is called Unwind Anxiety or Unwinding Anxiety. I might have had that wrong there. That gives lessons on what is anxiety. It's kind of like, it's not the free version of Nick, but it teaches you about what anxiety is. And it's by a psychiatrist who does a lot of meditation himself. Going to see Nick is better, obviously.
I have a free version of me too. So.
And then I think Nick touched on this, but I always like to really mention that I think mental illness is more than just, going to appointments or seeing your physician or your therapist. This is the American Heart Association's Essential 8, which includes getting adequate sleep, eating a plant-forward diet, moving our bodies, managing our weight, cholesterol and blood pressure, avoiding toxins, avoiding alcohol, smoking, things of that nature. But I have to also say that gut health is brain health. About 85% of the serotonin that our brain uses is formed in our gut. And so what that means is we do need to eat a well-rounded, when we can, array of foods, hopefully mostly found in their somewhat natural state, which I know can be a barrier, but there's lots of ways to get things in through smoothies, or I like to bake things into almond flour muffins and get veggies and fruits in that way if certain foods aren't palatable. But really including those whole foods in the diet as much as possible can be really helpful. Some quick resources. I found some interesting aging best practices on the global website for Spina Bifida. And it had some interesting things from a lot of different countries that spanned from having workshops in Malaysia to just educate about Spina Bifida, because a lot of families didn't know anything about it, and kids were being treated as if they had polio, and not realizing that they needed certain care, to like places like, I think it was Norway or something, who arranged cross-country, obviously a small country, but could be modeled state by state, little road trips for teens and adults with Spina Bifida, which might be things that you guys already do. And I think you're probably all familiar with this app, I bet. And then I think I wanted to say one thing about aging really quickly before we end and open to any questions. It's just that I was really reassured when I went through a lot of the research that more and more individuals are with Spina Bifida are growing into their 50s, 60s, 70s, and that it's actually a really exciting time. for individuals and their families. Nerve-wracking, but also exciting because it's wonderful that we're able to extend life. And I know there can be a lot of fear. So the research is really, really positive. So I think we have a lot of reasons to have a lot of hope and to support our full health, for many years.
We've kept you all too long, but thank you so much for coming today. Does anyone have any burning questions? And if not, good, go ahead.
I just, on one of the anxiety slides or depression slides, it said making sure underlying medical condition support the cause like constipation and headache. And I think that's a common kind of chronic thing. So how does that?
Yeah. So I think I would say different from baseline, right? So like if we're having, if maybe constipation is a chronic issue, well, let's do an X-ray and see, are we like more backed up than usual? Are we having worsening symptoms? Yes, obviously, right. Sure. Great question. Yeah.
And it's probably as soon as that gets treated, that specific thing, then we should expect maybe the depression to also improve too. So if it's not, then it might be time to treat that separately.
Yeah.
Is that or something separate? It's my daughter.
Yeah, so it is its own entity. We're currently co-located with a primary care office at Burnett Primary Care. We share space with other primary care docs there. I'm housed under the psychiatry department, but I work in the Freeman Center. Yeah, sure. Yeah.
And sorry, real quick, if you're leaving and you do have a question, it is okay to maybe contact Diane and she can get you our information, and we're happy to talk further about anything that you heard today. Sorry.
It was on one of the earlier slides. I'm sorry, about the rates of anxiety and depression in I must remember for anxiety. I was thinking about the
Yeah, we didn't spend much time on that. You're right.
Yeah,
Let me go back to that.
I think it's 21 to 45% of individuals may have depression. And these are, still on the smaller side, like, cohorts of hundreds. But yes, there's a clear increase, especially in the depression group. So, yep, wide ranges reported, 25 to 45%. Whereas if you look at the general population, I think that's kind of low actually, but most of the data said 5% in the general population. So much higher. And again, we think it's a complex interplay of a lot of these different things, from neurologic to physiologic to social to medical, that can impact it.
I'm remembering too that quite a bit of the association recognizes that they're diagnosed.
Correct.
So that number may quite a bit higher.
Yeah. Yeah, sorry, the 5% is in the general population, and the 25 to 50%. Any other questions? Yeah.
I'm curious. I use a beta blocker for performance anxiety.
Yeah.
So it's split up.
Yeah.
So I'm wondering, I don't hear about that one. Maybe it's prescribed for the anxiety, but because there's often occurring high blood pressure.
Like low blood pressure, or co-occurring high blood pressure. So I've used things like propranolol, which might be what you use, or Inderal, and quite frequently for things like panic attacks. Absolutely, yep, common to be used, yes. Yeah, some people can feel tired. Some people I find tolerate it really well. It's it can make you have weird dreams though. No, yeah, no, makes sense. Not always, I just warn people, I warn people it could, so that they don't come to me saying, how do you live about nightmares? So. Anything else? Thank you all so much for your attention.